different Latin American countries. So, Randy?
Thanks. First of all, I'd like to thank you for this invitation, and also like to say in the interest of conflicts of interest that I have no conflicts of interest in this, unfortunately. It makes me sad that I don't. Trauma in general and traumatic brain injury in particular are orphan projects, huge problems that have no champions, no celebrities running around championing them, no big foundations or funding agencies making sure they're well funded. And as a result, I have no conflicts of interest, so if anybody wants to correct that, I'd be more than happy to. What I'd like to talk about is traumatic brain injury trials in Latin America. And realistically, that's not a typo. I'd like to use what we've learned to suggest that the statement of think locally, act globally might actually be turned around in some respects to think globally, act locally, and how the realities of brain trauma in Latin America and in low and middle income countries influence the research that we do and what we can do for it. Everything we do, study, or published in the intensive care unit or in basically any trauma study in US or Europe is based on the availability of vast resources. Helicopters bring people in. We have dedicated trauma surgeons with ATLS training, meeting them, 24/7 imaging, rehabilitation, computerized triage, well-equipped ICUs, and lots of funding. And that's the case in most of the literature because most literature comes from the US and Europe. It's not detailed in the methods section. It's not controlled for in the statistical analysis. And it's not available, and it doesn't exist as the background of trauma in low and middle income countries. So how should a Latin American physician interpret the literature? Well, they'll read the same literature, and indeed they're very well read and as current as any of us are. But realistically, the question becomes, does the literature generated in the US and Europe at top-level trauma centers with every available resource generalize to trauma care in Latin America? And that's really a problem. What we have here is a fundamental disconnection, I think, between what we generate and what they read and see as reality and necessity and what they can do with that information. And I think it's a very occult disconnect. The playing fields aren't equal, but if you don't play on other fields, you never know that your field is different. Let's just give an example. Hypotension, low blood pressure, is absolutely a critical aspect of resuscitation of brain injury. It's a huge influence on outcome, and there's a lot of good studies to support that. This is just an example of one. This is the measurement of low blood pressure in the field up to and including arrival at hospital. One episode, not 20 minutes of hypotension. And you can see that when we control for other variables, that it doubles the mortality of brain injury, one short episode of hypotension. And I think you can also see, unfortunately, that it occurs in about a third of patients. So here's something of the 5 major predictors of poor outcome. This is the only one that can be prevented. It can certainly be treated, it can be prevented. It's incredibly important in traumatic brain injury. And so we figured that when we did one of our first studies in Latin America, a study at an emergency center in Rosario, Argentina, that we would see a strong influence of hypotension on outcome. It's certainly logical. And this was a very high quality study. They did a great job with us. Prospective study of 278 patients, 99% 6-month follow-up, which is hard to do anywhere, and they did it down there. For patients surviving greater than 24 hours, and we looked at the outcome at 6 months, the early hypertension was not a predictor of outcome. That's completely unexplainable. Indeed, there was very low incidence of early hypotension, which completely confused us. We had no idea why this could possibly happen because their patients don't come with helicopters, ATLS, bells and whistles. We didn't understand this, but when we looked carefully into the data and started to dig it out, we started to realize that early hypotension was so devastating that the patients actually didn't survive long enough to make it in the study. So not only was it a problem, it was a huge problem, yet the normal way of collecting data missed it entirely. So it's not only a problem, of course, it's a target, something we can address. Here's another example. We always want to do our outcome studies, and so we do the outcome studies in the way that we do them up here. We transport the research methodology down there. We do the same down there. And so, as usual, what we expect, coming from the first world, so to speak, is that we will do better. And that's what these data would suggest at first glance, is that the early mortality, 1 to 7 day mortality, is much better in a North American center, where I was at that time, Oregon Health Science University, than it was in Rosario, Argentina. However, there's another occult finding here that we didn't understand right up front, and that's that in the US, a lot of times when a patient comes in with devastating injury, we talk to the family, we look at the image, we tell them this is not going to have a good outcome. Let's consider what we should do. And indeed, it's quite common that resuscitation is slowed down or halted in the interests of quality of life considerations. That doesn't happen in Argentina. It doesn't really happen in Latin America. It's actually illegal in a lot of the countries. You can go to jail in Brazil for considering that. It doesn't happen in Southern Europe. So that's a whole population that actually is not generally entered in US or European studies because they don't end up going into the database because you don't study people that you're not treating vigorously. And it's a totally uncontrolled variable in comparative studies with Latin America. But if you add it in, all of a sudden you see there's not too much difference in terms of outcome, in terms of mortality anyway, between our center and the Argentinian center, at least within that interval. Another surprising finding, all led to by finding a group that we generally don't have, and they include, and we didn't understand the difference. It's really very important to make such differentiate, to pick up such data, because otherwise the comparisons are obviously correct, but obviously wrong. Now, if you go a little farther, though, it's interesting that if you look at the time between 8 and 19 days, which is often when they leave ICU and go to the ward, that we again see a difference. This difference we think is more real, and it shows that in the Argentine center there were a lot more deaths, and indeed there were a lot more deaths due to non-neurologic injury. And these patients have now left the ICU, which are pretty good, not highly resourced, but really good docs and the basic resources. And they go to the ward, which is not so well staffed and is really a little bit more of a wasteland. And these patients die of urinary tract infections, decubitus ulcers, pneumonias, etc. And so there is a difference there. And it's a difference you don't see if you do an ICU study, but it's a very important difference if you look at 6-month outcome. Again, that's a target. What you can do in those areas that to improve outcome, because you can do a great job in the ICU, but the outcome's the same if they die in the hospital after they leave ICU. Let's see if I can get that to advance. Not only do these often subtle differences influence our ability to compare outcomes, but they also significantly confound our ability to comparatively assess the effects of interventions on outcome. That's a lot of verbiage, but let me try to illustrate what I mean. We have a lot of toys, we have a lot of money, we've really come a long way in trauma in the US and Europe, and this is, you know, these aren't absolute scales, but we have really good care from pre-hospital, ED care, ICU, post-ICU floor care, inpatient, outpatient rehab, and long-term resources. Really, really good. Not perfect, certainly, but good. And so when we do a study in the intensive care unit, intracranial pressure monitoring or something, it reflects what's done up front, and we see the influence of hypotension. So that's really quite a reflection of excellent care but on the patients we get. And of course, you look at long-term outcome and brain injury, because you never get over it. You survive it, and it's a long-term problem. And that's all filtered through inpatient, outpatient treatment, rehabilitation, etc. So that's sort of the US-Europe. Now if you look at Latin America, the situation's a little different. Pre-hospital care, patients come in taxis. ED care is not very well organized. Sometimes it is, sometimes it isn't. ICU care is pretty good, mostly to the efforts of the physicians and the use of their resources. Post-ICU floor care is not so good. Rehabilitation almost never exists. So now you do the same thing. You do an ICU intervention, and that reflects their level of pre-hospital care, which is much less sophisticated. The long-term outcomes reflect all of the lack of post-ICU care. And so you can't be too surprised if you see a difference, not necessarily because of the ICU care, but because of all the surrounding effects. So you can't do research in a vacuum, and understanding the basics of these quote-unquote vacuums is really very difficult. There are a lot of major differences that you don't expect and you don't know how to measure. For instance, a lot of it has to do with financial constraints. When you come in, if you don't have insurance, you won't get some things. I've never had to think of that in my life. I do what's necessary. I use whatever toys are necessary to make the patient better. They can't practice medicine that way. That's their reality. It's just the way it is. But it's an uncontrolled treatment variable. When you look at the influence of treatment on outcome, you have to keep in mind that if they have a road traffic accident, they probably will have insurance. If it's a fall, they won't. Availability and definitions of rehab services. You got to know if they have rehab. So we asked for amount of rehabilitation time they got. And we based it on terms of physical therapy, PT. And we found they did get PT. But once we hung out long enough, we realized the PT wasn't physical therapy, it was respiratory therapy. Completely different definition of the same term. They actually get very little rehabilitation in hospital and none afterwards. And that's a huge impact on long-term outcome. Ethics and withdrawal of care. We've already seen the effect on apparent morbidity and mortality, but it also has to do with ICU beds. If they cannot say this patient's too sick to get one of our limited beds, they put the patient in the bed, the next patient comes in, may not get a bed. And that actually leads to a group we call orphan patients, which is an unbelievable group that we accidentally discovered down there. These are patients who would normally come in and get ICU care because of their brain injury, but they arrive at hospital when there's no available ICU care. There's no bed. So even though they would normally go to a bed, they don't get one. They go somewhere else and they get what's available. Endotracheal intubation, but no mechanical ventilation. This is a picture here, theoretically, of an orphan patient ventilator. It is a medical student or family squeezing a bag. Now that ventilator has to go to the loo sometimes and has to eat and can fall asleep versus a mechanical ventilator that doesn't. This is not optimal ventilation. Other things that happen: decreased monitoring, decreased nursing care and observation, fewer diagnostic studies. And this is common. Indeed, at one of our hospitals, a university-based trauma center, 72% of patients were orphan patients. That's a group that does not exist in the US or Europe and has never been described in the literature. It's a group that obviously has a huge impact on the outcome from brain injury, and we didn't even know they existed until we hung out long enough to actually accidentally discover them. Our colleagues down there were intensivists. Since these patients don't go to ICU, they didn't even know they existed. So it was an amazing finding.